Hi, everyone. Thanks for joining us for Conversations in High-Risk Non-Muscle Invasive Bladder Cancer. During this segment, we'll be discussing immunotherapy approaches in the treatment of BCG-Recurrent or BCG-Unresponsive non-muscle invasive bladder cancer. I'm Dr. Matthew Galsky, Professor of Medicine at the Icahn School of Medicine at Mount Sinai, and I'm joined by my colleagues, Dr. Joshua Meeks and Dr. Abhishek Tripathi. So the treatment of BCG-unresponsive non-muscle invasive bladder cancer really has been exploding in the past several years. And, in part, I think based on lots of interest in developing drugs with new mechanisms of action, and also based on really redefining this entity in a way that makes sense clinically and that could be used to inform eligibility criteria for clinical trials. So Dr. Meeks, can you tell us a little bit about the evolution of sort of the definitions of BCG unresponsive disease and how the FDA weighed in and really changed the way that trials were done in that space?
Yeah, I mean, I think we look at like who's unresponsive, right? We kind of know clinically what those patients look like, but I think the first maybe 5 years of the 2010s were getting a standard set of definitions, right? That patients have to be either BCG exposed, and adequate BCG has really been defined as 7 doses of BCG. So that can either be 5+2, it can be 6+1, but getting enough BCG to say you've had enough. And some of that is the number of doses, and some of it's the time. That it takes almost 6 months to get induction and a little bit of maintenance in. And that's because it's an immunotherapy, it needs some time. And then many of these trials, most of them in the BCG unresponsive space, as you know, are set up as single arm trials and really looking to get better than the standard, which right now, prior to checkpoint therapy was really kind of valrubicin or gemcitabine, which had anywhere from a 16 to 20% 12-month response rate. So a single arm trial trying to beat that has kind of been the goal. And so because of that, that's where we kind of are today.
So with sort of harmonization of those definitions, lots of these phase 3 single arm registration seeking studies seem to sort of get up and running around the same time. And I think probably Keynote 57 was the first one to read out, certainly the first one to have major impact in terms of practice. So I'll remind everyone, Keynote 57, a study in patients with BCG unresponsive non-muscle invasive bladder cancer giving systemic immune checkpoint blockade with pembrolizumab. The study had 2 cohorts, like many studies in the BCG unresponsive space. The endpoints are different if someone has carcinoma in situ, because of course that can be not completely resected and could be measured in terms of response to treatment, whereas patients with papillary-only disease, that's resected by urologists like Dr. Meeks. And then the treatment's really adjuvant. So time to event endpoints become most relevant there. So 2 cohorts in Keynote 57. Cohort A was the cohort with carcinoma in situ with or without papillary disease. And of course, when you can measure response, the endpoints come much faster. And so that was the first cohort to read out and showed a complete response rate that was reasonable with pembrolizumab, ultimately leading to the FDA approval of pembro in this space. So I'm interested to hear from both of you. I mean, this is probably the earliest clinical disease state in oncology anywhere for a systemic immune checkpoint inhibitor. We're treating a non-invasive cancer. And so, uptake, I guess, at your centers and how you guys think about this.
Absolutely. Happy to comment. So I think the uptake has been fairly slow, and I think we can talk about all the reasons that may be contributing to it. It is a systemic therapy, so these are some of the patients that have had no prior systemic therapy, so that can be a barrier, access to systemic therapy. So a lot of the patients are being treated with urology colleagues out in the community who may not have access to tertiary care centers for patient and cystectomies. Now, systemic therapies and cystectomy might be more approachable for them. I think those could be potential reasons. And then I feel like the number of patients that I've seen who were quite symptomatic from their bladder and quote unquote their bladder was not worth preserving in that setting because of a symptomatic standpoint. I think a lot of these factors play into how we utilize immunotherapy at several of our institutions.
Dr. Meeks, how about you?
Yeah, I agree with what Abhishek says. I mean, I think the biggest issue, I mean, you talk about it being early stage, but it's one of these tenacious cancers that the way I talk to patients is we just don't have the right, set of tools to be able to treat their cancer right. It's early stage, but really time works against you. And we know those CIS patients become T1 and become muscle invasive. And so we just don't have the right combination to turn the lock to unleash their, the best treatment for their cancer. And so, I do surgery, I do cystectomies, and we know the survival of that is really affecting patients. So if you can give someone a therapy and cure 20% of them, I think, it's a good therapy. Now, we don't use it as much as we think for a lot of reasons. Part of it can be as gatekeepers, as urologists. We don't refer people to medical oncologists. The other part, though, I find that when my medical oncology oncologists talk to patients, they talk about toxicity, and sometimes they're more for cystectomy than they are for systemic therapy. So I think, looking at the full spectrum of risk, benefit, and cure, I think we all wish the therapy was more effective. It's a new tool and it's going to cure some folks, but I think, we've all been pretty appropriate in how we've talked to patients, and the field has responded to that.
And I think, correct me if I'm wrong, but I think you did the first and maybe the only study of intravesical installation of immune checkpoint blockade. Is that right? And
Yeah.
what do you think the future is with that?
Well, I think it needs to be developed, right? I mean, it's a good option for people that can't get IV therapy. I think you can treat a lot of people locally, but the big take home I got from that trial is we saw systemic immune responses with local treatment. So even though we went into this thinking we could really treat patients that couldn't get systemic immunotherapy, we actually saw a lot of immune response. So I think it needs to be developed. I think it needs an industry to sort of work on dose and delivery and frequency, which, is really outside of what we can do at a single institution. So I'm sort of hopeful that immune modulation by directly addressing the bladder is a concept that will go forward from that work.
Absolutely. And even in more advanced disease, certainly could play a role. So at ASCO-G, we saw cohort B. Finally, we saw the results for Pembro in patients with papillary-only disease, and the endpoints that were reported in terms of disease-free survival, reasonable in the all-comer population, and it's sort of hard to compare that with the CIS population. And for a single-arm study with the DFS endpoint at fixed time point 12 months, sort of hard to wrap one's head around. But Dr. Meeks, Dr. Tripathi, what do you think about that data? And of course that the drug is commercially available. So do you think about using that?
I mean, I would say that, I see a lot of patients getting this already. Like, I don't think there's some patients who kind of got the therapy with papillary disease and didn't have CIS, and they saw a response. Some of them did. So at least we know there is activity, right? There is a decent response there. But I think we're going to have more tools soon. And in general, papillary tumors may have more targets. So, right now, you have that and you have chemotherapy, but I think there's more things coming. So I thought the data was a lot of what I expected, but I also think it said that it's safe and it's reasonable to use in a patient, especially when intravesical therapies aren't an option.
Sure. And among sort of those new treatments that are coming, we have another FDA approved treatment, right, recently. So we have nadofaragene firadenovec, and this is a non-replicating adenoviral vector, delivers interferon alpha 2b to bladder urothelial cells and induces an anti-tumor immune response. So, similar design, right, to the clinical development program for nadofaragene. So, Dr. Tripathi, how do you view these two treatments, right? We have studies that were done in a sort of similar fashion, but single-arm studies, CR endpoints in patients with CIS. One's administered intravesical, one's administered systemic. How do you prioritize these, and do you even think about using them sequentially?
Absolutely. And I think so. It's great to have two options in a similar sort of space with similar efficacy endpoints, but sort of different logistics and rationale for administering. So the things that I think about is the risk averseness to systemic adverse events and but the durability where we have longer term data. So I think, for instance, if you look at the Pembro data, I think duration of CR responders was about 24 months, and we have longer data for that. And in comparison, for the nadofaragene, we have about 9.7 months at this point. The 12-month durability was fairly similar, 19 and 20 something percent. It is important to know that one is systemic therapy again, so more intensive perhaps from a number of visits and the sort of with medical oncology and urology and so forth, compared to something that is administered intravesically. So it's great to have two options, one systemic and one locally administered, and gives us more options to discuss with the patients.
Dr. Meeks, do you think people will be receiving sequential lines of treatment for BCG-unresponsive disease, or you think that that window that you were talking about, we have to be careful about and sort of one shot and then cystectomy?
Well, again, it's time that works against you, I think, in this disease, right? Because it's there, and the key is, we think of going back to your first question about definitions. BCG relapsing patients, they do achieve some response, right? And so many of these trials made a note of if a patient had any response versus those who had persistent disease. I think those people who get some response, they tend to do better than those who just don't respond at all. So one of the benefits of nadofaragene is that it's given every 3 months. I mean, that's huge for the patient. So, if you can, do a therapy that has that big of a gap, that's great. I think the key with the Keynote 57 study is that if you don't respond by 3 months, you should be done. In rare cases, should you continue that? So if you get 3 months of therapy and you've not responded, let's move on to something else. And I think my hope would be that, either we get precision where you guys have figured out a biomarker that we could put people in the right groups, or we can quickly cycle through the therapies to find something that really works for them.
Sure. So we have readouts from lots of other data sets in this space. We have CG0070, we have Vicinium, we have N809. From a mechanistic standpoint, all of these are different in really exciting mechanisms, and interesting that these are distinct mechanisms from drugs that we use in the systemic setting for virtually any other disease. And so an exciting time in this space. Dr. Meeks, is there one of these from a mechanistic standpoint that you're particularly excited about, or from a clinical standpoint as well?
Yeah, I mean, the N803 data is really strong. And I'd say the challenge with it is that it has to be given with BCG. But I know, again, your group, for example, has done some work on other things that can be used to drive inflammation plus N803. So I think that's pretty exciting. But how these fit together, I think that's the most exciting part, is that we're not saying, you don't respond to BCG, I think we need to book a surgery for you. So my hope is that we can have multiple of these options for patients.
Dr. Tripathi, how about you in terms of some of these new treatments for BCG-unresponsive disease?
Absolutely. I think Dr. Meeks mentioned it correctly. I think that's one of the highest excitement we're seeing. The BCG remains a challenge. I think alternative delivery of drug might be an interesting proposition as well. So we have had some experience with TAR-200, which is an intravesical drug delivery system that releases gemcitabine for a longer period of time and has better exposure characteristics inside the bladder. And I think the downside is that it can have some local side effects in terms of insertion, but I think that's quite promising, and early data is quite interesting as well. It's actually being combined with immunotherapy in the muscle invasive and non-muscle invasive space. So there are multiple trials that are ongoing, and these are going to be truly for the patients who are BCG refractory or develop subsequent progression to muscle invasive disease. So I think that's an interesting modality and basically more efficient way of delivering intravesical chemotherapy.
Yeah, I think that data is fascinating in the fact that it's a drug that is used for BCG unresponsive non-muscle invasive bladder cancer, but just altering the PK of the same drug that we use can produce profoundly different results. And I think there are bigger lessons for us to learn in terms of anti-cancer drug development there. So thank you both for joining me in this discussion. It's been really interesting. And thanks everyone for joining us for this segment in immunotherapy approaches for the treatment of BCG recurrent and BCG unresponsive non-muscle invasive bladder cancer. Be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios. Thank you.